Join Dr. Joseph Massad and guests as they educate and enlighten listeners around the world with unique patient cases and technology. Brought to you by the Massad Learning Center. For more information on how to take your practice to the next level, please call our office at 918-749-5600 or visit our website at joemassad.com. This is Dental Discussions with Dr. Massad.
Welcome. This is Joe Massad, and this is the second podcast. I tell you, the first one was a lot of fun. I'm going to tell you something today that, I had some problems with dentistry and with certain patients. I bet you everyone out there has had something that was difficult. So I had a patient that came in, and she couldn't open her mouth much, hard at all. She had scleroderma, advanced, along with Manal's disease. Pitiful. She was referred by another dentist who was getting ready to retire, and he said, Joe, can you take this patient over for me? She's going to be a little bit tough. And I said, sure, no problem. When she came in, I talked to her, and she says, yeah, I'm ready to have all my teeth out. And I couldn't even get in her mouth, virtually. I could barely get in. And I said, my gosh. She told me about her illness. And I said, okay. And you look at her, and she had real wide teeth. Well, I didn't fault anyone because they didn't look that good. But the dentist who sent her to me, I felt bad for him because I couldn't even get in her mouth. I don't know how he did those crowns. So here we are going to do upper and lower extractions and put her in fixed cases. So I have to say, okay, I'm really good on making impressions, but how am I going to do a scan on this patient? Even a scan would be difficult. So we wanted the smallest tip we had. They did at that point in time. It was still big, but not small enough, but we did our very best. So I got the patient in, and we talked exactly what we're going to do. I also then contacted a maxillofacial surgeon who's also an oncologist, and so he has a lot of skills, and he told me, yes, I think I can do this case. So I had to get now records. I got the smallest I could at that point in time, the scanners. We gave her something to relax her. I brought in several people to help me. And then what did we do? We were finally getting a scan at a time. We scanned the entire dentition, very difficult to do. I felt bad for her because even though she was lightly sedated, she still had to move a little bit for us. So we were able to go ahead and finish with the scanning, take the bite, okay, do our very best to get the palate, okay, and all the areas we needed, completed with that, and then we did complete digital. So we had this, but I didn't want her to have these wide teeth. So I said, we need to design this to have very tiny teeth for her. So we did, all in a digital environment. I had my technician here, okay. We had someone also to help us with our CBCT because we wanted to make sure we had the proper, CAT scan for this. So at the end of all of this, we decided that this patient would have fixed upper and lower. The upper would have to be zygomas. Gosh, I hadn't done a zygoma case, so my surgeon would do this, but now we have to go for planning. So digitally, my surgeon is now looking in, and telling us what we're going to be doing. And then we went ahead, and that day that we scanned, we then took photos on the patients. We did several CTs. We then designed digitally the teeth, which would be much, much smaller. At the same time, the surgeon told us about where the implants would be. So we had to put all of that in, but yet I didn't really know how to do it myself. So we brought in someone to do this. I'm going to introduce you to him in just a bit, but to let you know that I didn't know I had the capabilities of doing that. So it had to be a team. We had to bring in, the A team to do this. And it was really exciting, nervous at the beginning, not knowing what the outcome would be, but I had the good people around me. That's what you have to do. You have to bring other people in. Now, how was I able to do that? Well, gosh, I've been doing dentures for many, many, many years. I've been doing overdentures. I've been doing fixed dentures, but yet I never had one that I couldn't even take an impression. So this one was a little bit difficult. So I brought in the A team. One of the A team members is here, and his name is
Tim Todack. I'm the director of HGX Well for North America, and I'm the company that has the CBCT that we use. And so we worked with Joe. Joe brought me in to be able to help with not only scanning this patient, but being able to actually go through and help to digitize the image and then help to do the planning with the work with the surgeon to look to where the implants need to be, make the plan for that, but also be able to take in the dentures and scan those, create those into a model that we could then put them back in, so we knew when we put those implants in where those implants would then match up with the new dentures, so we could already make that plan. Being that this patient had a mouth that couldn't open very well, that our concern was that we really had one chance to be in that mouth, and the time of surgery was going to be that time.
Listeners, before we dive deeper into the procedure, let's take a look back at how Dr. Joe and Tim met many years ago.
It's actually a pretty good story.
Before I met him, I was in South Korea, and I met with the company there. And it was just amazing when I looked at this CBCT, and I already had a CBCT, but the ability of what this new one would be able to do just was fascinating. So I said, "Are you in the States?" "Yes, we're just now getting into the States." I said, "Okay." I says, "I'd like to have this configured." So when I first met them in the States, about a year later, I says, "Is that the one I'm going to buy?" They says, "No, we haven't built yours yet." So I had to wait until they built mine, and then I got it. Yeah.
And then it
That's
always
what I'm
became
into.
something where I found a reason to be out here at least every month and a half, because there was always going to be something new. There was always going to be a very interesting case. And over the last 6 years, I've got to know their staff, become friends with everybody that's out here, and to be able to work with some very interesting cases and doctors that pour into here to not only learn, but university students. And from here, I've been able to do lectures at other universities where I'm able to go through and teach universities about CBC technology, and take myself away from being a director of a company and really go in there as an educator as to the technology, so that when they are students, they're learning how to be a dentist, but they don't learn about the technology. And so I give them the opportunity to learn about the technology, so when they get out into their practices and they need this, that they have a better opportunity to understand what they're buying and why. And if they choose my company, that's fantastic, and I hope they do. But otherwise, they're at least an educated consumer, and they're going to get it's going to be best for their practice. And again, all this has been made possible by my relationship with Joe. It's actually a pretty good story, because I became the director at the beginning of 2018, and we were actually at the end of 2018, and I was at the Greater New York Dental meeting. So this is my first meeting as director, and we're here with mostly our Korean team, and I'm the only English speaker in the booth. And so as I'm the only English speaker in the booth, I'm there, and this gentleman walks up to me, and he has an entourage behind us. And literally he has an entourage of like 5 doctors. They're all following him like they're all residents in a medical school. And I'm going, who is this guy? And he walks up and he goes, I saw your machine in Korea. I want one of them. And I'm thinking, who? He said, I'm Joe Massad. And I got his card, and I was very intrigued. And all the doctors behind him were just going back and forth and saying who Dr. Massad was. And I kind of absorbed it. I was still a little overwhelmed at just becoming the director, and kind of absorbed the moment and said, well, I probably need to go out and visit Dr. Massad. So I went out and I flew out to Tulsa. And again, being that I travel over the United States, you got to go to Tulsa. And you're thinking, Tulsa? Okay. What could be in Tulsa that could be that big of a deal? And I roll into this office that is a dentist's dream. This has probably the most technology I've ever seen in an office. I have helped him over the years do lectures to students, and I say, this is the dream office. This is where you want to be. This is how you want to have your technology be. And working with Joe over the years to be able to do some very interesting cases. And at that point, you just kind of realize that I'm in a different realm of dentistry. I'm in a different place of that. I get to do some very amazing things. And I've told the story throughout the country of working with Joe Massad. And I usually start off with, hey, do you know Joe Massad? And amazingly, I would say over 90% go, yeah, I've either read his book, I've heard of him, I've heard him speak. And it's the idea that that it is, you're so well known and people know of your work and know what you've done throughout your career, but then that when there's something super complicated, or if I have something in my computer and somebody wants to say, well, I'd like to do challenging cases, I just kind of giggle and I pull up a Joe Massad case, and they kind of go, oh, well, not that challenging. And so it's always a great story to be able to do that, because for me, myself, as the director of this company, it's given me great opportunities to learn. I've grown in not only my dental knowledge, but also the ability to be able to reach an audience that I never have before, simply because of the fact that you have a reach beyond most people I've ever known, and being able to do cases that most people would never touch. And it gives people the dream when we show it to them later on that things are possible. And I actually now teach courses in digital dentistry, and I leave This is the Dream as my advanced course. And my advanced course, I show some very complicated cases, and I say, but this is what the dream is that someday this can be a workflow that can happen, so that it doesn't have to be that one magician in the world knows how to do this, is that more and more people know how to do this. Because someday, I doubt it, Joe may retire, I doubt it, but in that sense that somebody's going to need to be able to take up that magician's wand. And in that case, that being able to let people know that it's possible is the way that I can pass along his knowledge base to other people and say, this is where we need to use this technology to do that.
And that's why I teach. I want someone to take my place. Many guys to take my place, not just one. Yeah.
Now let's get back to the procedure with Teresa.
When we put those implants in, where those implants would then match up with the new dentures, so we could already make that plan. Being that this patient had a mouth that couldn't open very well, that our concern was that we really had one chance to be in that mouth, and the time of surgery was going to be that time.
The surgery actually took almost 8 hours, seven and a half hours surgery. And so how did the patient, what he did, when she was intubated, right, he was able to open her. Okay, and she was hospitalized.
And so we wanted to be able to make it to where we could have a denture that was very close to completion, because we knew where those implants were going to come out of the bone itself, have that denture so close that while that patient was still under, we could be able to complete that, because we already had the planning done by doing a process we call dual scanning, which means that we scanned the patient, and then we also scanned the dentures that the patient had at the time turn those dentures into a surface model to put back into the scan so that then we can do the planning from there forward. So on my screen here, I actually have an image of her original scan that we have. So if you look at her, you can see that this is our patient here to begin with. So this is her original scan. And you can see, again, what he was discussing about the large teeth on the maxillary area. And you can also see that she had a Lafort procedure done. So she has these plates also up here. All these are all challenges to the fact that we have to put implants in there, and we have to be able to find places to have those implants be, as well as find room to put a denture into place. Looking at this right here, you can also see that her bone is unique in the fact that it isn't just in normal maxillary bone. This is more contiguous, and instead it's actually kind of out this way. So making a denture for this was not your average everyday denture that we were going to create. So now as we put this into place, that we had to be able to make some choices as to how we did that. So one of the things we first started doing is we went ahead and took a digital picture. So with an iPhone or with a digital camera, we took a 2D picture, a JPEG, and we were able to wrap it around the skin model of our patient. So with that in mind, I could just be able to take her skin and match up points on the 2D picture with the 3D model, so we can be able to see what her skin looks like on the outside. So again, matching up those things so we can see what she's going to look like. Then from that point forward, we went through, and with the discussion with the oral surgeon, we decided where the implants needed to be. Being that I teach the software and I work with the CBCT, that I was asked to be able to help do the implant planning so that I could put it on the CBCT so that Dr. Massad had that information. And so we took her dentures when they were in her mouth, we put markers on them, and then we took dentures outside of her mouth. We took the images or the CT of the dentures outside of her mouth, and we turned them into STLs or surface models, and then put it back into the software. So that when we did, we had a overlap of the CBCT of her bone network as well as the model of her dentures. So now we could see where those dentures were touching her bone, so that when we started planning the implants, we would be able to choose where those implants not only could come out, but where they would go in and do that. The oral surgeon asked me to do 2 zygomal implants, 5 across the top, 5 across the bottom. And so we have a video that we can show on that surgery and what we ended up doing with that. And so going through that video real quickly, as we can see here, first of all, this is our patient, and getting her in the machine itself, this is how we scanned her. So as we went through, we used an edentulous cup, so we actually got her an occlusion. I think that's really important because, as Joe said, that she was a challenge to not only open her mouth, but to be able to get an occlusion that worked for her. So this was her original teeth and an original scan, be able to go across and get her. You can see she kind of has an open bite. And then we were able to scan her and go ahead and get the full digitization of the head. Then moving over, we're able to then center her and then take one of her pictures that we took from her. And now we're able to overlap that picture by picking out points that match onto her skin model. And now you can see that her 2D picture is now wrapped around her 3D model. So now we have essentially much like a facial scan, we have it to where now we can see what her facial features look like matching up to where her skin is as well. And now we can start the process of doing the implant planning. So in doing the implant planning that we went through, and again, this is the process of taking those dentures that we did and turning them into STLs, and then putting them back in, again, finding common places where we could put these markers into place to put the dentures in so that we knew where the dentures were supposed to be from where they were living originally. Once we knew their position inside the patient's mouth, then I could go through and be able, with the help of the oral surgeon, now start placing the implants. As we placed the implants, then we were able to do things like a bone density graph to show the quality of bone that those implants were going to be in. So much like that last one that we saw that was the zygoma, that we not only could tell where we were going to be in the zygoma, we could actually see the quality of bone that it was going to be in. So that gives us an assurance that we were putting it in bone that was going to be steady and stable for her for this procedure. So going through and again, finding the right bone, finding the right trajectory. And also, as you can see the overlap, you're going to see not only where those 2 zygomal implants are, but you can also see where they're going to, you'll see the overlap right here. You can see where that denture is also, so we know where it's going to contact the denture.
How do we make those teeth smaller? Digitally. So we actually had her teeth, and then we decided we make them much smaller, but we're still within where the ridge is, okay? And then I went ahead, and when we were completed with that, we milled it. We didn't just do just something like a print. We wanted it to be strong. And how many did I do? I did 3 upper and lower cases because the surgeon needs to have a little bit of wiggle room. Maybe during the time that they're going to be doing the transition, by golly, it could break, something should happen. Give your surgeon something extra so that they're not, stressed out. And so that's what I did. I made sure he had 3, prosthetics. And that way it's much easier.
And again, at the time of surgery, now he has options. He has all those digital prosthetics ready to go. So as we've already started to plan, that now we have our implants in place so that as we keep moving on with this case, that now we have our implants planned. We know where those dentures are going to sit, where those implants are possibly going to come out, or at least have a great example of that. And as we move to our final picture, here's our implants in place. And then this is where the dentures are going to be as well. And so now we can see the conglomeration of both of those together. So that in the end, that when the surgery actually came, that we were in a situation in which that the oral surgeon knew where he was going to be putting the implants and knew the quality of bone and the approximation where they were going to be. Dr. Massad had implants, had the prosthetics ready to go, and had a number of versions of them ready, so that, and we had it all planned digitally, so that we all, as a team, came together to be able to make sure that this could all work very smoothly, because it was kind of a one-shot deal, because while she was intubated, we were able to put in the implants and have the prosthetics put in all on the same day. And so this is kind of the beauty of being able to put all these things together and do something like what we call dual scanning, so that we can plan this so that in a patient like this, we have the opportunity to give her her teeth and we get ready to go. So this is the post-operative of Teresa Watts. So again, you can see, here's her implants, and to change the view for here a little bit, that this is her post-operative. So all that planning that we did went through, and you can see here, these are our implants finally in place. And so again, just so you can see the final endpoint of our planning and the surgery itself, to be able to see where we ended up doing so, and then they'll have a picture of Teresa that we can put in at the end with her smiling.
Tim, thank you so much for coming in.
My pleasure.
I tell you, this has been a lot of fun. I just want the listeners to understand that sometimes you are confronted with something that you don't know what to do with. Give us a call. We'll tell you what we've done. Hopefully it's going to help you too. I don't expect everyone to do things like this, but I always do what? Get the best surgeon I can. I put good people around me so it will be successful. I'm not going to do everything. I'm going to have a team approach. And I think that's very, very important. You're going to hear from Dr. Silva, and I think it's going to be very interesting. I've had a good talk with him, and we'll see that in just a minute.
I would like to introduce you to Dr. Silva. Doctor, would you like to tell the audience what you do?
Yeah, sure. Thank you. It's my pleasure to be here with Dr. Massad and everyone else. I am a maxillofacial radiologist. I went to dentist school at Columbia University. I graduated 25 years ago as a dentist. I practiced general dentistry for 15 years. Then I went back into teaching. I taught for 11 years at Columbia. And while teaching, I actually took a leave of absence and became a radiologist at the University of Washington, Seattle. I've been now a radiologist for 10 years. So after I completed my training in 2015, I went back to teaching. And then after the COVID surge, I went back to private practice. I still have an appointment at University of Washington, Seattle. It's a remote appointment as an affiliate professor. My practice is mostly radiology, but also it has a very large component of guided implant planning. So I work both as an implant planner for guided surgery as well as a radiologist.
Great. So we started actually consulting with you when we got our new CAT scan, and sometimes I want to have a little bit more than just the teeth, especially when I go above the sinuses. Okay,
Right.
and then I start to call you and say, hey, how about seeing if there's any pathology? And at the same time, I've asked you about even the density of the bone in these areas. And
Right.
so tell the audience what you've been doing for me.
Yeah, so you're following the standard of care in the sense that if you do a cone beam CT scan, whatever is captured in that volume is your responsibility to make sure that there are no incidental findings. Pathology, fractures, anything, mostly pathology. So when you capture scans, you send it to me with a prescription, the things that you're looking for. Let's say I'm looking to do a full arch reconstruction case here, so I can give you some opinions so far as the amount of bone available, the bone density, but also I'm looking at the rest of the scan to make sure that there are no pathologies. Because if there are, some need to be referred. Some can go along with in time they heal, and most commonly maxillary sinus mucosal thickening. They're often seasonal. So the radiologist is trained to tell whether the presentation of the patient requires further evaluation, and oftentimes the referrals need to be made to a physician. So that's what we do. We work with the dentist acquiring these scans to both address what they're looking for in particular, but also making sure there are no surprise findings in the scan.
Oh, that's great. So you really have assisted me with several patients, and from time to time, you've actually caught something that I had no idea. Can you kind of elaborate on maybe one of those items?
Yeah, so you had a case in your office of this patient who came in complaining. She had some dental procedure done recently. And I forget exactly what it was. I think it was something related to implants. It wasn't an implant placement, but it was something related to implants. And so she came back complaining that she had a pain in the posterior maxilla, and she had an earache. And then a scan was taken, and then when the scan got back to me and I looked at it, she had no oral findings. What she had was in both ears, the ear canals, she had a growth of tissue that actually started growing into the canal. And when it hit the tympanic membrane, it had no more place to go further medial. So it just started growing against the tympanic membrane. And that's what was giving her the pain that she was complaining about. Now, as dentists, we're often here, well, I'm having pain in my ear. It can be wisdom teeth. It can be a TMJ. There's a very intimate relationship with the TMJ and the middle ear, both geographic and innervation. So we're trained to think, okay, earache, dental office, dental problem. This lady had a problem that actually you referred to an ENT, and she had that excess tissue removed, and she's fine. So that's the kind of thing that we do, because a dentist is trained to look for dental problems, right? You take a scan and most dentists don't really look beyond the oral cavity. The radiologist has training in both dental radiology and part of our training in becoming a maxillofacial radiologist is at the University of Washington, we have to do 5 weeks in, 5 months in neuroradiology. So we completely leave the dental service and we spend 5 months with the neuroradiologist, and all we do is look at medical problems, medical scans. So we're not being trained to read neuroradiologist scans, but we're trained to recognize what they are, and so we can make a referral. So that was the case in your office that struck me. It was the most peculiar case where we can make it a point it's worth having your scan read by a radiologist, because there oftentimes are many things in it that have nothing to do with dentistry and may be causing the patient some pathology, either silent or in the case of this patient, it was acute.
So we sent this patient to a physician, ENT physician, and I sent your findings. It was amazing because this physician now sends me patients.
See,
Because
yeah.
all of a sudden, oh my gosh. And
I know.
yeah.
I know.
So yeah, so
that-
that's been amazing. Yeah. Thank you so much for all that. I just,
yeah, it's my pleasure. That's what we do.
yeah.
That's
So
what we do.
I just
For the
wanted
longest
all of
time,
yeah, go ahead.
no, I was just going to say, so for the longest time, there has been kind of like a separation between medicine and dentistry, in the sense that because we're so far apart in that the education is oftentimes done at 2 completely different institutions, and the practices, we don't practice in hospitals mostly, but now we're at a point where we're capturing so much of the non-oral cavity areas that having a specialist look at it, you can make a more educated referral back to physicians, and it kind of blurs this imaginary line that we have that medicine and dentistry are different. They're not. We all belong. Dentistry belongs to medicine. It's just a specialty of medicine. It's just for a matter of convenience over the, I don't know how long, it's been decades. There has been this bifurcation in the road, but we work parallel with them. So.
Well, I want to thank you so much for taking your valuable time, and it's a pleasure working with you. I feel comfortable. I take a CT, and maybe it's above certain areas, and I said better send it bit to the doc, and then you come back and give me the findings. And I think that's really good for dentists to understand that if you're going to go above what we know in dentistry, okay, go ahead and send this to a radiologist who does oral areas. And I think that's very, very important. I don't know if dentists really understand that if you do that, maybe we have a responsibility, okay, to send it to someone and make sure there's none other things, because I wouldn't have known that.
It's too little, too late. Doctor, you've been sued.
I just think this is a good thing for dentistry, and thank you for taking your valuable time to talk to us today.
Sure, you're welcome. It's a pleasure.
Yeah.
Pleasure.
You.
I want to say one thing about the referrals. They're often seen as just another expense, but there is a different way of looking at it, and you actually brought this out a few minutes ago. Oftentimes, when not all incidental findings need referral, and not all incidental findings are referred to either a physician or a surgeon or an endodontist. And I'll give you a very good example. One of the things we find the most for the last 2 years, it's actually a bit disturbing because no one can figure out why. One of the things we find the most are either internal resorption or external resorption of teeth. Mostly internal than external, but we see some external too. And the thinking here goes like this. So you take a scan, and let's say you're doing an implant at position number 5, but tooth number 12 is undergoing internal resorption. So if it's caught early, you can do an endodontic treatment and save the tooth. If it's caught too late, then the tooth needs to come out. Most likely an implant goes in. But if you catch it early and the patient has an option to either get a root canal treatment or get an implant, you're giving the patient that option. The patient starts looking at you as like, okay, so this guy's good, right? If you don't catch it then, when it's salvageable, and then later the patient comes back to you because you are the treating dentist of record, and now you, let's say tooth number 12 is hurting or it broke, and then you say, oh yeah, you've had a problem with it. Well, you never told me I had cavities. Well, it's internal resorption. Yeah. So think of it this way. What if the patient asks you, was it there when you did the other implant? And then you go back in the skin and you look and it's there. So you kind of, how do you get out of that? Catching it early brings about a good view of the patient that you are a very good dentist. Having to explain later why it wasn't caught early when it showed on the CT scan might kind of cloud the waters there. And also you can find things that need to get done that you wouldn't find otherwise, particularly again, internal resorption. There are many things that need to be done that require attention in a dental office that are not, if not caught, then later you might have to do a more complex extraction with complex grafting with barriers. And let's say you don't do that yourself, you're going to have to refer this out to periodontist or neurosurgeon anyway. Whereas if you have caught it earlier, you have a much better outcome and a much better patient view of what you do. So, and as you said, you referred to the ENT for a case there was no expectation on their part to have a dentist make that diagnosis. But now they're sending you back cases because they kind of figured this guy's good. So there's a lot of benefits to that. Plus, not the least of which is that you're covered. One of the worst things we can do as practitioners, medical dental, is to get some kind of test, an examination, blood tests, ultrasounds, CT scans, even radiographs. And then later find out that there was something in it that we didn't report. And now we're trying to catch up. It brings problems with state boards, it brings problems with the patient's perception, and it can bring problems with the legal profession as well. So it's a good thing to invest in getting them read.
Well, so this has just been tremendous, good information, and hopefully all of our viewers will be able to avoid having problems when they do their CT scans. So thank you so very much for coming. And I'll be sending you another case probably tomorrow. Okay.
Thank you, and I'll be glad to read it.
Thank you.
A good day to all.
To all.
Thank you.
You have been listening to Dental Discussions with Dr. Massad. For more information on how to take your practice to the next level, please call our office at 918-749-5600 or visit our website at joemassad.com.